Worldwide, IUDs are the most commonly used reversible contraceptive method. The use of IUDs in the United States is also increasing, both for contraception and for local progestational effect. Sonography has an important role in the evaluation of IUDs to confirm the correct position and to assess for complications. Therefore, imagers need to know normal and abnormal appearances of IUDs. The objective of this presentation is to review the types of IUDs and normal and abnormal sonographic appearances, to discuss the role of 2D and 3D ultrasound, review the pitfalls and artifacts related to IUDs, as well as the complications. The indications for the use of IUDs includes reversible contraception in women with at least one full-term pregnancy, the treatment of endometrial hyperplasia, as part of a hormone replacement therapy regimen by providing local progestin in combination with estrogen given by another means, as well as more recently the treatment of excessive uterine bleeding, be it idiopathic, adenomyosis, or small fibroids. These are the two IUDs that one is most likely to encounter in clinical practice. On the left is the copper-bearing Paragard IUD, which has a T shape, and on the right is the plastic Mirena IUD, which contains progesterone. Note that the horizontal upper arms of the Mirena are angled inferiorly at their distal tips. There are three types of IUDs: the inert, the copper-bearing, and the hormone-containing. Of the inert IUDs, there are the plastic polyethylene IUDs that are impregnated with barium for radioopacity. Some of these are of historic interest, such as the Lippes loop, which one may still occasionally see in an older woman, the safety coil, and the old Dalcon shield, which was very problematic. A widely used inert IUD is the stainless steel ring that is very widely used in China. And this is an image, a multiplanar image of the stainless steel IUD. This IUD is not as effective as the IUDs that are most commonly used in the United States. Here we see the ring in the coronal plane. In this case, a pregnancy occurred, and we see that the IUD here, represented by these two echo densities, is adjacent to the gestational sac. Note the ring down artifact that traverses the gestational sac from the metallic ring. Here is the Lippes loop. In the coronal plane on a 3D image, we see the serpiginous course of the Lippes loop, and the typical clue to this IUD on 2D sonography are the 5 echogenic foci aligned in a straight line with shadowing. Now, of the copper-bearing IUDs, the most common that you're likely to see is the Paragard T-shaped IUD, which is available widely in the United States and is effective for 10 years. One may see also the copper 7 IUD. Now, these copper IUDs have highly echogenic straight shafts or vertical portions, and they have crossbars that are also highly echogenic and that form the shape of a 7 or a T. The copper-bearing IUDs cause their effect by a local increase in copper levels, which leads to decreased sperm motility, irritation of the endometrium, and possible ovicidal activity. Finally, the hormone-containing IUDs are used for contraception, endometrial hyperplasia treatment as part of hormone replacement therapy, and the treatment of menorrhagia and anemia. Of these, a most likely one encounters the Mirena, which includes a synthetic progestogen, levonorgestrel, which is highly effective for 5 years. Another one is the Progesticert. Now, the Mirena IUD is T-shaped plastic polyethylene with barium sulfate for radiopacity. It measures 32 millimeters in length and 32 millimeters across both of the arms. Remember that the tips are angled down at the end, so this should not be confused for fragmentation. Now, the vertical stem of this IUD has a reservoir containing the hormone and is thicker than the remainder of the IUD. The characteristic appearance of the Mirena is that only portions of this device are highly echogenic, unlike the copper IUDs. So the Mirena can present a problem with imaging. The earlier versions of the Mirena were very difficult to visualize sonographically, and I'll show you examples of that. And the string could actually be more echogenic than the IUD itself. The more recent versions are more easily identifiable. The vertical shaft is more echogenic, and the IUD string is slightly less echogenic. The horizontal arms with their characteristic downturn distally are still difficult to image. So again, this is what the IUD looks like. The contraceptive effect is mostly due to the local effect of progesterone. Women that are of fertile age still have ovulatory cycles with follicular rupture. The other thing to note about this IUD is that the atresia of the follicle may be delayed because of the progesterone, and the follicle may continue to grow, so that enlarged follicles have been found in approximately 12% of women using the Mirena. What are the reasons for referral for ultrasound in women with IUDs? Commonly, the thread is no longer visible or palpable, and there is concern about expulsion or a broken thread or retraction into the uterus. Also, there may be a clinically apparent change in the length of the thread, which suggests the possibility that the device has become displaced. Now, increased menstrual flow, especially after a period of time where the flow has become diminished, which is what one expects, may be a clue to expulsion. Pain raises concern for embedment. There may be signs and symptoms of infection, or the patient may present with amenorrhea, which could be a sign of concerning for pregnancy. What is the technique that we use to evaluate these patients? We routinely do take a quick look transabdominally, but usually this is not sufficient. Occasionally, because of their highly echogenic nature, one can determine the location of the copper IUDs transabdominally. Usually, though, we use transvaginal sonography, and when using 2D ultrasound, very careful scanning in multiple planes that are sagittal to the endometrium as well as coronal to the endometrium to try to recreate, as it were, in our minds, the configuration of the IUD. 3D ultrasound can be especially helpful for women with the difficult to visualize Mirena. Finally, recording a cine clip can be helpful for study after the examination to assess the position of the IUD. What are the complications and findings of IUDs? Myometrial penetration or embedment may decrease the contraceptive effectiveness of the IUD and may be seen in conjunction with pregnancy. The embedded IUD is usually removed, and it may be removed with some difficulty, and it may require the patient to be taken to surgery. Expulsion can be partial or complete, abnormal position, fragmentation, pelvic infection, and finally pregnancy, intrauterine, and ectopic need to be searched for. Now, here's an example of a case where the IUD is located in the cervical canal, and when the IUD is in the cervical canal, it is less effective as a contraceptive, and here we see that there is an early intrauterine gestation. Here is a 3D image showing that the long stem of the IUD is embedded into the cervix. Here is the short stem of the IUD in the cervical canal, and the other short stem is located in the upper cervical canal. Here, another example of an IUD. The long stem is in the cervical canal, and the short stem is perpendicular to it, coming out at us, embedded in the lower uterine segment in the presence of an intrauterine pregnancy which progressed normally. Uterine perforation is the most serious complication of IUD, and the literature shows that the frequency varies between 0.05 and 13 per thousand insertions. The frequency varies with the factors related to the patient, the operator, and the type of IUD. It is important to be aware of the fact that approximately 15% of IUD-related uterine penetrations lead to serious complications in adjacent visceral organs, primarily the intestines. So obstruction, penetration, intestinal infarction, mesenteric injury, rectal strictures, and rectouterine fistulas have all been described as complications of uterine penetration by intrauterine devices.